welcome to our departmental lecture of today. We have a busy program as we have 2 lectures for 1 hour, so we will start immediately. And therefore, I first present you Mrs. Alice Cavolo. Alice comes from Italy. She got a master's degree in philosophy from the University of Trento. She got also a Master of Bioethics from KU Leuven, and currently she is in her final stage of her PhD. She got a PhD mandate from the FWO, and the topic of her PhD is the ethical decision-making process for resuscitation of extremely premature infants. The co-promoters are Bernadette Dirkse-Kasterlee and Gunnar Naulaerts, and I am the promoter of this project. So my name is Chris Kastmans, I forgot to say that, and I give now the floor to Alice.
Okay, thank you, Chris, for the presentation. We don't have a lot of time, so I'll try to go straight into it. As Chris said, the PhD topic is about whether to resuscitate preterm in general, but today I want to discuss more in specific if we have to resuscitate the premature born at 22 weeks of gestation, which corresponds more or less to 5 months. So we will start with a short introduction in which I will explain who these infants are and what are the medical facts, very quickly what are the recommendations, and then in the second part we will do sort of an ethical analysis, so we will see what are the ethical principles applying to this specific case. So I thought it could be good to start with a picture of a 22-weeker, just to have a visual idea of who we are talking about. And I think it's pretty clear from the picture that the child is very, very tiny. It's still more similar to a fetus than a proper formed baby, and that will need a lot of support, which is indeed the case. These infants will need to be immediately resuscitated, intubated, as you see from the picture, and normally they will endure a stay in a neonatal intensive care unit for around about 5 to 6 months to be able to survive to discharge. So the first decision to make is always, do we resuscitate them? And to decide that, the first thing that we look at is obviously the chances of survival. And we see that for these infants specifically, the chances of survival worldwide on average are around 30%. However, this is a statistics that is valid at a population level. It doesn't really say a lot at an individual level. So there is still a lot of uncertainty on what are the specific chances of survival of each individual child. And that is because the week is only one of the many factors that will determine what are the specific chances. Some factors are clinical and as such are more objective and easier to take into account. I reported here just few examples. Weight, for example, is still a very, very important factor, because if the child is not at least 450 grams, then the chances of survival are almost zero. And to give you an idea, the baby in the picture here was around about 560 grams, so pretty good for a 22-weekers. Another very important element are condition at birth. So if there are any other anomaly, that's of course a negative sign, because you're adding problems to problems. And to the opposite, if the child has at least a spontaneous attempt to breathe, that's a positive sign, because it's an indication that the lungs at least know what they have to do. Another very important element will be postnatal events. These are all traumatic events that can happen during the neonatal intensive care unit, and that might lead the child to either have a very bad quality of life or to death. The most commons are infections and cerebral bleedings. And that's to say that unfortunately, the fact that the child will survive resuscitation is not really a guarantee that the child will survive. There are, however, other factors that are not really clinical, but they still have a huge impact on the outcomes, and as such, they are a little bit more difficult to take into account. The main factor here will be geography. I said before that 30% chances of survival is an average. In reality, it can be quite different. Low-income countries, for example, do not resuscitate these infants because they do not have the resources to do so. So there the chances are actually 0%. Then you have the exceptions of Japan to the opposite, in which they do resuscitate systematically everyone, and the chances are around 60%. And then you have a lot of countries in between in which they do resuscitate 22-weekers, but more on an occasional basis. It's more on exceptions, and there the chances really vary between 10 and 30%, depending on how often this is done. So you can see that where you are born in the world actually makes a huge impact on whether you will survive or not. Another very important factor is disability. Now, these infants normally have a much higher risk of severe disability compared to children born at term. And severe disability can mean different things, but I decided to give you a practical example to give you an idea of what is the type of disability that doctors are really thinking at when they are considering not resuscitating for disability reason. So this is a case of a 23-weekers actually, so it's a week later, but it's a case from the 70s, so it's comparable with the 22-weekers nowadays. And Sidney Miller received full resuscitation and full intensive care, so it was not a problem of lack of care. And in her teens, she was still partially blind, incontinent, quadriplegic, she had seizures daily, and the mental capacity of a 6-month-old child. So this is, of course, quite an extreme example, but it's really to make clear that the extreme example are what you are really thinking at, not severe forms of disability that are still compatible with good quality of life, like deafness, for example. However, it's still important to keep in mind that this is a very medical description of disability. It doesn't necessarily say a lot about the quality of life perceived by Sidney Miller. So it is important to remember that, because we know that even people that had the idea that they could have never lived with a certain disability and that they considered it completely undignified when they found themselves in the situation, they actually reported a good quality of life and they were pretty happy despite the situation. So this really shows that we need to be very, very careful in translating what is our idea of disability to other individuals. So this is more or less a very summarized clinical panorama. So what do the guidelines say? Here, the majority of guidelines agree that at 22 weeks, you should not resuscitate. It is also important to remember that a guideline is not law, which means that exceptions are always feasible. And we see that in the majority of countries, exceptions are done. However, the general advice given to parents is that they do not resuscitate. So here we start with the ethical analysis, and when you think at doing an ethical analysis of a clinical case, normally the 4 principles that always come in mind are autonomy, non-maleficence, beneficence, and justice, in this order. However, when it comes to a child born at 22 weeks, of course, autonomy cannot be put first because the child is not autonomous. And indeed, the most important principle here is the best interest. This is really a very special case of beneficence, so you should always pursue the good of a patient, and non maleficence, you should avoid pointless harm for a patient that has been created specifically for patients who are not autonomous now and who have never been autonomous before. And that is because the general idea is that you should make a decision that is in line with what we know of the patient and his values. And this sometimes justified making decisions that are not maybe the best clinically speaking, but they are the best for these specific patients. However, when it comes to a newborn, that's not feasible because there is no way in which we can know what the patient would want for himself. And because of that, the best interest says, well, you have to pick the absolute best. So, which means that we need to do a harm-benefit analysis of each individual option to understand which one has the maximum net benefit and the minimum harm and risk, objectively speaking. So we have here 3 options. The first one is resuscitation, and resuscitation has the advantage of giving the child a fair chance of survival. And that fair chance is very important because it clarifies that we are not guaranteeing that the child will survive, but we are giving him a chance. The disadvantage, though, is that there is a lot of pain and suffering involved in treatment for 22-week years. First of all, because resuscitation itself is a very painful and invasive treatment. And if you go ahead with intensive treatment, then you will have a good 5 months of painful and intensive treatment. So it's quite a lot for a child. Moreover, when it comes to 22-week years, it's even worse because there is a very huge difference in terms of development between 22-week years and then 23-week years and onward, which means, first of all, that they are so immature that really everything creates discomfort for them, even like things that are not that big for other patients, like having a light on, the constant coming and going of people, even closing a door, for them is extremely discomforting because their nervous system is extremely underdeveloped at this point. So that is a problem. And these are things that you can mitigate, but you cannot completely remove them. And on top of them, as I said, there is a huge gap and a huge difference between 22-week years and any other preterm baby, which means that what works for other babies does not necessarily work for 22-week years. But at this point in time, we are resuscitating them only exceptionally. So all we know is anecdotal. And that means that doctors are really learning while they are going, and there is a very high risk that they will harm the child in the process of understanding what's the best to do for this child. So to give you a very simple example, if you're in intensive care in hospital in general, you have blood taken every day. That's like a normal part of being in a hospital. And normally you do disinfect the area to avoid infections. And this is particularly important for these children because the immune system is among the things that will develop completely only later. So they are at a higher risk of infection. This is why infections is one of the most common occurrence in neonatal intensive care. The problem, though, is that at this point, the skin is also extremely thin and very frail. It's also not completely developed yet. So they discovered that by doing that, they were actually burning the children quite severely. So they had to stop doing that. And they are trying to find a better solution that will work for these infants. But until they burn a child, they didn't understand that this would have been a possibility. So there is an element of almost experimentation when it comes to these children. So all of this, of course, would be justified if the child survives. But it's a lot less difficult to justify if the child does not survive, because at that point, all of this will be done almost for nothing, quote unquote. And then, of course, there is the risk of the child surviving with severe disability, but we already saw that this is a very difficult element to consider in the resuscitation decision. The total opposite option would be no resuscitation. And here it's very important to understand that resuscitation does not equal non-treatment. It equals palliative care. So you're basically doing everything you can to avoid any pain, to keep the child comfortable, warm, and especially to allow direct contact with parents, which is not really that possible if the child is in an incubator. Of course, disadvantage, though, is that you're not even giving the child a chance, which means that you might have not resuscitated a child that could have otherwise survived. There is actually a third option that is called a trial of treatment that seems to be kind of a medium between non-treatment and full treatment. That would be you start with resuscitation, and if the child survives, you admit him to intensive care. And then you keep the child constantly checked to ensure that the child is progressing well. And if it's not progressing, at that point, you can redirect care towards palliative care. So this has the advantage that the child has a chance of survival and that you are avoiding therapeutic obstinacy because you can always redirect care. It also has a huge advantage for the parents. That is, that can be useful for parents to really realize that the care is not going to work, that the child would die anyway, and it can be helpful to accept the fact that the child is dying. And it can also be helpful for the mourning, because it's very, very difficult for parents to cope with the idea that they didn't even try. We know that even parents that decided to go towards non-resuscitation and they are convinced and they rationally know that it was the best for their child, they still sometimes have that moment of, but what if I tried? So this might help to removing that what if kind of element. It's not really helpful for the child, but it is helpful for the parents. However, this is not really a golden solution for everyone. There are some harms also connected with this option. The first one is that the resuscitation might be unsuccessful, or there might be any other kind of sudden events, and you might not be able to redirect care fast enough. So you won't be able to manage the pain successfully, basically. The other big problem is that we know that even if ethically everyone agrees that withdrawing and withholding are comparable, withdrawing is psychologically more difficult, not only for parents, but also for physicians. And that means that not only can be like psychologically more harmful for parents to go towards withdrawing than just withholding, but also you might push the baby a little bit too far until you arrive at a point in which it's not really appropriate care anymore and you should have stopped earlier, or again, that the child is able to survive on his own, but with a very, very severe disability. And also, this might not be the best choice for parents who are really, really worried for the suffering of their children and that believe that 30% chances are not enough for justifying intensive care. So, sorry, all of that to say, I hope it's clear from the presentation of the three options that all of them have good advantages and very big harms connected to them and very big risks. So it's not really so straightforward to say that one is objectively the best, and the best will depend on what are different people's interpretation of this data. So you might have people that believe that life is a value in itself, and so they will believe that resuscitation is the best interest, and others that will believe that quality of life is more important, and they will prefer to go towards palliative care or a trial of treatment. So you can see that the same principle ends up justifying completely different options. So the second principle here would be autonomy. And of course, we are not talking about the autonomy of the child here, but more the autonomy of the parents. And there are very good reasons to include parental and respect parental autonomy in the decision-making process. The first one is that in our societies, parents have the right to make decisions for their children in any other field. So why should this be any different? And the second and more important is that the parents are really the one that live with the consequence of the decision. Either if that means having to mourn a dead child, to take the risk, or to take care of a possibly very disabled child. So they have at least to have a say in the matter. However, we also all agree that parents are not really allowed to do whatever they want. They still have to comply with the best interest, meaning that if they decide for something that is obviously against the best interest and it's harmful for the child, then doctors should intervene and refuse the request. The problem is that we saw that it's not so easy to understand what's really the best interest of the parents, and there is a very high level of subjectivity involved. The last principle is justice, and justice here can refer to two different aspects. The first one is resource allocation. So the question is it fair to allocate so much resources for infants that have such a high risk of dying? And the ones that are in favor of resuscitation said yes, because in effect, NICU is cost effective even at 22 weeks. Because if the child survives, obviously resources are justified. But if the child dies, as sad as it is, normally they die rather quickly, so they don't take up so much resources. However, the counter argument here is that if we do that systematically, then they might not be as cost effective anymore. This is not necessarily a reason not to do so, not to resuscitate, but it's more a way to look at the problem and say, well, if we decide to do that, then we need to have an honest look at our budget, understanding what is the care that we can provide to these children. And if we see that we don't have enough to be able to provide care for all the children, because of course, if you start doing resuscitating systematically, you will start have a lot more children coming in. Then you need to adjust your budget and you need to adjust your resources to ensure that you can actually provide care, optimal care for everyone. And the second point would be justice as equality. So the idea is that you need to treat children that have the same prognosis in the same way. The problem is that this is not exactly what's happening here, because we have a guideline that says that you should not resuscitate at 22 weeks. Generally speaking, these children are not really resuscitated. Parents are not really given the chance, which means that we are not resuscitating some children that actually have the same chances of death and disability of all their children, for which we never even consider not to resuscitate, sometimes even when parents actually ask us not to do so. The problem is that this argument can be easily flipped, because you can say, well, maybe we should stop being so aggressive also with older children, and we should start to have more of a shared decision making with parents and ask parents what actually they think it's the best for their children. Another problem here, and it's actually connected, it's what's called the self-fulfilling prophecy. This means that we don't resuscitate because they don't really have a high chance of survival. But if we never resuscitate them, then they will never survive. So you create kind of an infinite loop in which you will never arrive at a point in which the care for these children will be good enough to make them survive. And this seems again proven by the fact, and I think that here the best example is Sweden, because Sweden until around 2004, they had a non-resuscitation policy for 22 weekers. And then it changed, and they say, okay, there should be a shared decision making between parents and doctors, and it needs to be decided on a case-to-case basis if resuscitation is appropriate or not. And in a year's time, since the new guideline comes in, the chances of survival of these babies tripled, which means that if you start to resuscitate them more often, they will also survive more. So to go back to our original question, that was, should we resuscitate 22 weekers? This is my take, and I would like to hear yours, but I hope that from everything I said until now, although it was a little bit condensed, it is clear that it's quite a difficult situation, and it's not so easy to give an answer. And I do not think that we should find a simple answer, and even less that we should find a one-size-fits-all kind of answer. So I do not think that we should systematically resuscitate every single 22 weekers, because the chances of survival are not good enough, and more importantly, we are not good enough to provide them optimal care. So it shouldn't be done for everyone, but it should be done on a case-to-case basis, more or less like Sweden is doing. Parents should be involved in the decision-making. They should be explained all the harm and benefit connected with all the different chances like I did, and there should be a decision based on a case-to-case basis, which means that both resuscitation and non-resuscitation should be allowed. And I do believe that in this specific case, parents should have the last word, because they are really the one that will live with the consequences, and we don't have enough data to be able to say that one option is really so much better than the other. So the last word at this point should be of the parents. And yeah, that was my presentation. I put here a couple of articles if you want to know more. And thank you very much for listening to me.
Thank you very much, Alice, for this very nice presentation. And you left also a few minutes for questions. So if there is someone who would like to ask a question, the floor is yours. Who is willing to ask a question? You can immediately or directly intervene if you want.
So, Alice, this is Dina Davis. I have a question.
Hi.
Hi. Thank you. That was terrific. I wonder if you'd done any thinking about the research into the possibility of using an artificial womb for 22-weekers to get them to maybe 26 or 28 weeks, and what you thought about that.
I kind of did, but it's not really feasible at this stage for 22-weekers, because the artificial womb, to be able to survive, the child needs to be able to pump the blood independently, because if you try to pump it from the outside, they tried that with lambs, not with babies, and they sent, it doesn't work with the pressure of the blood, and they go into cardiac arrest, so that's not really feasible, which means that at 22 weeks it won't be feasible for everyone to be put on how it's called, on the bag, basically. So it's not necessarily a solution for everyone, and that also poses a second problem that will be, at least at the first stage, when they will be able for real infants and not only lambs, then they will be quite expensive, and there won't be that many of them as any other new technology that arrives. So I doubt that they will decide to give them at least systematically to 22-weekers when they have such a small chances of survival, while we know that they will be much more effective for 23-weekers. So I think that at least for this first stage, it won't really be an option for them.
Thank you.
No problem.
Is there another question? Is there someone who would like to ask another question?
Hi, Alicia. This is Fabienne Doubles speaking. Thank you so much, and also for being the first in this new type of departmental lectures that are also part of the doctoral program. So thank you so much. I have a question regarding boundaries. You said that the timing is 22 weeks, but aren't you concerned that parents or maybe physicians will try to even move that deadline, that timeline, pushing that back? So what about the pregnancy of 21 weeks and 6 days? Sometimes hard to prove it's exactly 22 weeks. So how do you see this evolving in the future?
I think it will evolve naturally. At this very moment, I'm not very concerned with the risk of trying to push the boundaries down, because the community of neonatology is proven to be quite conservative. So it's already difficult enough to try and convince them to start resuscitating at 22 weeks. So I doubt they will go so fast into the 21 week. But I think that, as it has always been, while we become better with 23 weekers and 22 weekers, then we'll probably move back down also to 21 weekers. But for the moment, it doesn't seem physically feasible to make 21 weekers survive. Like, the only situation in which I foresee that might happen is if the child is in such a good condition that they actually think that it's an older child, because there is always a doubt on the week. So if they see from all the condition of the child and they see that probably it's actually a 22 weekers or even a 23 weekers, maybe they might consider it. But I don't think that the boundary will push down very, very fast, honestly.
Okay, thank you. So thank you, Alice, for your presentations. Thank you for the questions. And then we move now to the second speaker, and she presented already herself, or she intervened already in the discussion of Alice's presentation. So the second speaker is Professor Dina Davis from Lehigh University in USA. Welcome, Dina. Dina is our guest this week and next week at the Center for Biomedical Ethics and Law. She did research on the ethics of reproductive technologies, genetic dilemmas, but currently